Welcome everyone. My name is Danny Tucker. I'm the Director of Clinical Training and I've been here at Townsville Hospital now for 12 years. I'm an obstetrician and gynecologist by trade. I have been a past clinical director and I'm committed to my part in making this a great place for people to work. I want us to be able to grow professionally and to actually enjoy our time at work. I do believe that is possible. I want to speak for a few moments about the pressures you might be feeling in medicine, about our expectations as an organisation in terms of what we want to see from you, and also about what patients and families need. You've been doing medicine now for long enough to know that medical school probably didn't teach you everything you need to care for your patients, and sometimes it feels a little bit more like this. The word patient comes from the Latin word meaning to suffer. Our patients suffer not only from the physical discomfort of their disease, they also suffer from the emotional anxiety, sadness, fear, and loss of dignity. This disease-inherent suffering is only one aspect of their condition. Sometimes the system that they are in causes avoidable suffering. Sometimes we as doctors cause it inadvertently, not because we're bad people or because we come to work wanting to harm people, either because we don't know how to alleviate it when it's needed, or because we're pushed by a system into providing care that's not compassionate. So when considering this, what do our patients actually need? They absolutely need high quality, safe medical treatments, but also physical safety in the environment that they're in. If they walk into the bathroom and find someone else's blood on the toilet seat, they won't feel safe. They need psychological safety, and this comes with the trusting relationships that they build with healthcare professionals. Of course, they need confidence that they're getting the right treatment, but they also need to know that they're being cared for properly, that we as a team are there for them. For example, when I'm taking a patient across from the birth suite to the operating theatre for an emergency caesarean section for fetal distress, of course anxieties are high. And as we wheel across, I'll say to the patient, our anaesthetist today is Dr. James. She's a really good anaesthetist. If I was going to sleep, I'd be happy for her to be the one to do it. And that kind of reassurance of speaking well of each other can give patients great confidence about our system. Simple words such as, we're going to look after you, are enough to enhance that. When we show confidence in each other, the patient feels confident about their overall care. I've spoken about inherent and avoidable suffering. Avoidable suffering can occur when we fail to connect with our patients or when we fail to acknowledge them as fellow human beings who matter. It's important through things like breaking bad news that we are present both physically and empathically for them, that when they suffer complications or deficiencies in our service, that we apologise. I know that my clinic is always running late when I am down there. It always seems a bit tedious maybe to me to be opening every consultation with an apology, but I know that that connection and that apology tells the patient that I value their time as much as my own. Avoidable suffering can occur when we treat the person as a disease rather than an individual themselves. And this is often shown through non-verbal communication. Good eye contact is always important. I know that we're sitting in front of computers constantly nowadays, and we can't usually remove the computer, but acknowledge it and bring it into the conversation. Again, I usually say to patients, I will be looking at the computer. It's not because I'm not listening to you. And just bringing it onto the table can make it more acceptable. It's important to think about your physical body position and your any contact you have with patients. Their patients are really looking for kindness that goes beyond the medical care that's delivered. Patients need coordinated care that makes sure that they see the people they need to see when they need to see them. There's no point having a patient rush through a discharge if they're only going to be readmitted a few days later because of a deterioration of another disease system. It's very disempowering being a patient, and this loss of autonomy can be returned by careful consideration about when we can give our patient choices. And the more choices we can give them while they're an inpatient, the more they will feel they have control over the outcomes that are important to them. Sometimes these can be big decisions about whether they have surgery or not. Sometimes they can be even the smallest decisions, for example, whether they have their blood taken from their left or right arm. Each choice that they are presented with returns them some control. Everything I've been talking about is the care beyond medical interventions. These are the things that are important to our patients, beyond, of course, receiving high-quality medical treatment. So what about the hidden curriculum of medicine? Do we need to speak about that? Is there a negative culture in medicine that is preventing us from doing the best for our patients and for each other? Reduced accountability is really around the changes in medical working hours that means a given health professional may not feel as much ownership of a patient as occurred in the past. Long-term relationships with patients are rare, particularly in hospital medicine. We've all felt the culture from the top, from burnt-out, jaded senior doctors. Of course, we all need to be medico-legally astute, but legal phobia has its dark side, and defensive medicine is not always good for patients. You've all experienced electronic health records now, and there is a clear link between burnout in doctors and poorly designed, unintuitive electronic healthcare record systems. Difficult patients are angry, emotionally needy, or they ask too many questions. And negativism about patients is a part of the hidden curriculum, including avoidance, when in fact these patients are the ones who need more of our time, attention, and compassion. Our emergency department director used this term at a recent head of departments meeting, and it does accurately describe the type of behaviour that we've all seen within craft group discussions. Ones where other specialties are spoken badly of. This type of conversation is divisive and it creates an unnecessary negative culture in medicine. The challenge of reconciling these two competing influences on your life as a doctor is a real one. The question is, did medical school properly prepare you for this challenge? Because everything that I have experienced tells me that there are some gaps. Did medical school emphasize how important knowledge and skills in these areas are? I know that when I was a new intern, I thought teams worked like this. When you're near the bottom, you just do what the person above you says, and if you're lucky, everything will be okay, the patient will get the treatment they need, and the system is functioning perfectly. But you know this picture much more accurately describes the system that you work in every day. It's called a complex adaptive system, and the rules of engagement are very different to the hierarchical system I showed you on the last slide. If the coronavirus pandemic has confirmed anything for us, it's that we are currently living in a very VUCA world. VUCA stands for volatile, uncertain, complex, and ambiguous. And although the acronym has been around for many years, the importance in medicine and the ways that we need to engage with systems are only really starting to be defined more clearly. Here's a summary of 3 important domains from this study that looked at how to succeed in complexity. First of all, embrace the complexity. Understand the processes of care. Understand variation in care and what the different types are and why they occur. Seek to understand the system that you're working in and how do you align the priorities of everybody involved. Actively engage people within your network, make the relationships and facilitate dialogue. Foster a culture of willingness to learn and freedom to act. Learn constantly and adopt a growth mindset. Of course, act scientifically when we can, but it's important to understand that in complexity, we often don't have scientific or well-proven solutions. When you're dealing with people, when you're dealing with systems, try and take opportunities as they arise, identify potential solutions and test them out and iteratively develop the best one for the job at hand. I'm talking about the system itself here and like how you solve day-to-day problems of getting the work done. I'm not talking about medical knowledge as such. Even in how our systems work, it's important to adopt a mindset of continual search and for the best way to do things. This is the Health Leads Framework. It's a leadership development framework, and it's one that's been adopted by Queensland Health and by our organisation for the development of leaders within the hospital. In the beginning of the careers, we often develop how we lead ourselves and how we engage with others before moving on to the more higher level domains. And what's interesting is that when I looked at assessments of interns, RMOs, and even on registrar training programs, 2/3 of assessment criteria relate directly to the lead self and engages others' domain. And so although doctors are very keen to get on and to learn the medicine that achieves outcomes or that might be innovative, it's really important to understand that you are going to be judged in your early, mid-careers on how you lead yourself and how you engage with other people, mainly because it's so important to the practice of medicine. So I've covered a range of skills and approaches that I want you to think about when we try and keep our patients safe and when we try and thrive in complexity.